Good afternoon. Should I wait for some more time? Should I start? I think I'll start. Okay, so ventilator waveform analysis. Now, this is something which is always asked, something which we should all know. And besides the basic, we'll be covering a bit about desynchrony, asynchrony as well. So, this is something more that we expect from candidates nowadays. So, we all know that the four parameters which are measured on our ventilator screen are four, basically flow, pressure, time, and volume. So, all those scalars and loops which you see on the screen are all just a mix and match of these four basic values. So, if we were to look at the graphics, so we can definitely understand that what is the mode of the ventilation is going on, whether there is any pathology in the form of autopy, is there any asynchrony or dysynchrony in the patient, and accordingly adjust the trigger levels, measure the work of breathing, adjust the tidal volume, try to avoid over distension and subsequent hemodynamic disturbances, assess the effect of bronchodilator therapy, detect equipment malfunction, and so on. Now, starting right from the basic, every breath has four phases. Okay, something with regards to the ventilator, something which starts the breath, which is we all know is known as trigger. Then, as soon as the breath is triggered, the inspiratory valve opens and a flow is delivered. Once the inspiratory time is over, the inspiratory valve closes and the expiratory valve opens. This process is called cyclic, and finally the expiration goes on. And breath is what is determined by these four phases. So, if you were to take the scalars first, there are three basic scalars and they are all against time: pressure time, flow time, and volume time. If it were a volume control ventilation, we have the volume time, the pressure time, and the flow time. Remember, flow is the only thing which goes onto the negative significantly as compared to the positive. Flow towards the patient is the upward part of the curve of the graph. Flow away from the patient, that is back into the ventilator, is the downward part. So, if you understand the direction of flow, you will also understand what you mean by air leak and what you mean by other things I will tell you. Each mode has a different shape. A volume time graph, obviously, when we talk about flow, the flow is fixed. So, a fixed flow state, it rises, which is a peak and a plateau, and then it just falls. The inspiratory and the expiratory form of the volume control is sharp, expiratory is passive, but the way it is, and the pressure will have a rise. So, the variable here is pressure. The volume is fixed and the flow is fixed. In pressure control, the pressure is fixed. Unlike the volume control curve, where the inspiration was sharp rise in the volume, here is a more gradual rise. Why? Any idea? Because it's got a decelerating flow pattern. So, the flow is highest to start with and then decelerates over a period of time. What this deceleration allows is slightly more time for inspiration. So, it allows the slower and the late opening alveoli to also open up over a phase of time. So, that's the reason why the volume, instead of being sharply rising, rises in a more gentle curve. The expiratory phase is always passive, it's going to be the same for both volume and pressure. The pressure is fixed, obviously. So, this is absolutely basic, so let's not just dwell on this, there's a lot more to cover. So, if you want to use a pressure and time curve or the pressure and time scalar, it can give you some basic information and can provide you some idea about the pathology. So, basically it tells you whether it's a spontaneous breath or a mechanical breath, whether it's a controlled or an assisted breath, and what are the components of the inflation pressure. Abnormalities, it tells you whether the airway resistance is increased, whether the flow is adequate or not, whether there is decreased lung compliance and there is So if you were to see a spontaneous breath, you see a negative inspiratory effort, because after all, spontaneous breath means you have triggered it, the patient is triggering the breath, so this is a negative inspiratory effort. On the other hand, a totally controlled breath where the patient is paralyzed has no triggering effort, so there is no negative spike on the pressure time scaler, so it starts right from the baseline. I have already commented about this, why the rise is so sharp in a volume time and why is it so gentle in a pressure time waveform. Triggering can be seen by a negative spike from the baseline. The baseline corresponds to the peak. See, it's not starting from zero, it's starting from a certain level of pressure. So obviously some positive end expiratory pressure is going on. On top of that, the patient is taking an inspiratory effort, so there is a decline in the airway pressures transiently, which forms a trigger. And if it's above the trigger threshold, it's going to lead to a flow. This very well denotes that the patient is triggering the breaths. Given the slope of this curve, the rate of rise in pressure in a volume control ventilation, the pressure time curve, the volume control ventilation, you can say whether the flow is adequate or not. If the flow is adequate, there will be a uniform rise in this curve. If it is inadequate, this curve will be scalloped out, saying that the flow is not adequate. So something has to be done to increase the flows. If you want to break down the pressure time curve into parts, at the beginning of inspiration, there is a rapid rise in the pressure. And what does this correspond to? Sorry? No, this is a pressure to overcome the upper airway resistance and the equipment resistance. Right? That's why it's very sharp. Once it reaches into the lower airways, here it becomes a more gradual rise. It rises till a peak is reached. In case you have set a pause time, a pause time means that there is a zero flow state. The inspiratory valve is closed, the expiratory valve is closed, and there is no flow. In case you have set a pause time, what happens is that some amount of pressure dissipates. And how does it dissipate? Because of slower opening alveoli. Some alveoli open up later, so some amount of the pressure is dissipated into this alveoli and more of the alveoli are open. So there is a fall from this to this. So this level is what's called the plateau pressure. So plateau pressure is a time when the alveoli are open and the pressure has disseminated and sort of dispersed into all the alveoli. So that's more of a reflection of your pressures at the level of alveoli. So the plateau pressures are the one which you are really concerned about rather than the peak pressure. So peak pressure goes into the airways, the bronchi, bronchioles and so on. But once it comes into the alveolar level, the plateau pressure makes more of a difference. Once the expiratory valve is opened and there is cycling onto exhalation occurs. PEEP is the rise in this pressure curve from above the baseline. If you have increased airway resistance, so obviously which part of the curve is going to be increased? It is this part and this part. So the entire rise part is increased. So this is normal as compared to a patient with a much higher resistance. This resistance could be anywhere along the tubing, along the upper airways, anywhere. It could be bronchospasm, even proximally it could be tube occlusion, anything. So that's going to lead to a much more higher level of the rise plus a much more higher level of the peak inspiratory pressure. So the peak inspiratory pressure is going to be high, but once there is a pause time, this is going to dissipate again into the alveoli, and the plateau pressures will be more or less the normal because it was all in the airways and not at the level of alveoli. So there is an increased peak to plateau difference when there is increased airway resistance. On the other hand, if you have decreased compliance, this part of the curve is not really much changed. Upper airways are okay. It is the lower part, the alveolar area, which is more of a concern. The lungs are more stiff. So the peak pressures are reached and then very less redistribution because most of the alveoli are collapsed here. There is not much area to redistribute. So the plateau pressure is also equally high. So the peak plateau difference, the overall graph is enlarged and the peak plateau difference is small. The peak is also increased, the plateau is also increased. increased. There the peak was increased, but the plateau was normal. So the peak and plateau difference is less. There the peak and plateau difference was large. So high resistance, large peak to plateau difference. Low compliance, small peak to plateau difference. Peak inspirator pressure is raised in both. The plateau is raised in this, but the plateau is normal in resistance. So this is a comparison of all three. This is increased resistance, this is low compliance. The next curve is the flow time curve. So again the same thing, the same amount of information plus something more. Now the flow time deals with inhalation and exhalation. So obviously anything which obstructs exhalation can be very much seen on a flow time curve. That's why you're going to be seeing obstructive versus active exhalation, response to bronchodilators, air trapping. So anywhere wherever the flow is restricted, air trapping is a form of flow restriction. Okay. So which subsequently leads to increased volumes, but it is inherently it's a flow related problem. Right? Air leak is a volume related problem. So if you understand this basic concept, you will know where to look for it. Right? So it has a positive part which is flow towards the patient and a negative part which is flow away from the patient. Flow away from the patient is passive exhalation. So any obstruction to the flow away from the patient, may it be within the thorax or within the tubes, will also be manifest in this part. So this is considered to be the peak inspiratory flow rate, the topmost part. This is considered to be the peak expiratory flow rate, which is the bottommost part. This entire thing is the expiratory time, and this is an expect start rate. Now, the flow time curve of, say, a volume control versus a pressure control is different. A volume control is a fixed flow state. The flow will rise, stay at the fixed flow level till the inspiratory time is over, and then cycle to exhalation. The pressure control, on the other hand, has a decelerating flow pattern. The flow rises fast and then decelerates over a period of time throughout the inspiratory period. If there is an inspiratory pause, it's a zero flow state, as you can see here, a zero flow state, and then exhalation. If there were no inspiratory pause, the exhalation would have started right from here. So the very fact that there is a gap between the inspiratory part and the expiratory part tells you that there is a pause attached to it. Do we need to keep a pause always? Not necessarily. Only when you want to calculate something that you keep a pause. Air trapping. Air trapping means the flow is not getting emptied. The alveoli are not emptying out. The flow from the alveoli is not emptying totally before the next breath starts. So it's a flow related issue. Inspiratory is pushed with pressure. Exhalation is passive. So that's where the problem starts. Here the peak expiratory flow rate is also reduced. And the expiratory time is prolonged to such an extent that it is not complete before the next inspiration starts. So you have the next inspiration starting from below the baseline. So the next inspiration is starting from below the baseline, and this very well says there is some amount of air trapping going on. There is some amount of auto peak which is being generated. So an obstruction will lead to a decrease in peak expiratory flow rate and a prolonged expiratory time. On the other hand, if you have an active exhalation, you will have a very active or very big peak expiratory flow rate and a very short expiratory time. So you are actively exhaling out. The response to bronchodilator therapy can also be understood. The PEFR will increase as soon as bronchodilators work, and the expiratory time will also be reduced if it works properly. Now air leak, what's happening? So you can see air leak here, it's inspiration, exhalation, and the exhalation is going towards the positive. What does this mean? Some amount of volume is getting lost on the inspiratory aspect. That's the reason why it is crossing the baseline. And this is where the importance of flow towards and flow away becomes important. Right? So, where is your flow sensed? You tell me, in your ventilator. Yes? During the inspiration or during the expiration? Expiratory mode, right? So, obviously, if there is a leak, it's going to be from the positive end rather than from the negative. So, that's the reason why it is here rather than here. So, air leak is manifested by a rise from above the baseline auto peak is manifested as a rise from below the baseline. Third curve, volume versus time. This is of volume control or pressure control? Pressure control. This was a very sharp rise. Volume control. Pressure control has a more curved kind of rise. So volume control. Okay, so what goes in should come out. You understand that much? Nothing should be left inside. So what goes in and more comes out. Obviously, you are exhaling from your reserve volume, so that's why more will come out. And that's why there will be a fall from below the baseline. That means more of amount of volume is being exhaled out as compared to what is actually gone inside. Air leak, what goes in, all of it does not come out. Some of them is lost. So the volume does not reach the baseline. So this is air leak. Now coming to the loops. The loops are against volume. Scalars were against time, this is against volume. Pressure volume, flow volume. So the very same thing which you saw in scalar can be seen in loops as well. You can reconfirm the same thing on a loop. Now when you talk about a loop of flow volume, the volume is on the x-axis and the flow is on the y-axis. This is the inspiratory part, this is the expiratory part. So the inspiration starts from the functional residual capacity, reaches a peak inspiratory flow rate and goes all the way along the volume curve till the tidal volume is achieved. Right? Exhalation is passive, it comes out, the peak expiratory flow rate and comes back all the way to the FRC. So this is how the normal curve is. In case there are secretions of condensate in the tubing, so that tends to splosh around. It doesn't affect the inspiratory part because the air is being pushed through with force. But when it comes to the exhalatory part, this water tends to just oscillate, and that leads to a kind of an oscillatory descent of this expiratory curve. If there's air trapping is the flow related problem. Flow is not going to reach the baseline. Air leak was a volume related problem. The volume won't reach the baseline. So here the flow does not reach the baseline. Now if I were to show you this and I'll say this is air trapping or air leak, you should be able to say immediately because you understand that air trapping is a flow related problem. Keep that in mind. The same thing, if you want to show it, air trapping in this and air trapping in this, on a pressure time it shows that on the flow time the flow does not reach the baseline and the next inspiration starts. Here it will manifest as the flow not reaching the baseline before the next inspiration starts. Air leak is a volume phenomenon. So the volume does not reach the baseline. The volume does not reach back to the FRC, it stops somewhere before. So what went in, something else came out. So there is something which is leaked inside. Airway resistance. Now any kind of airway resistance can be very well seen on the exhalatory part. It affects both inspiratory and expiratory, but the expiratory part is more affected because it's a totally passive process. By increasing the pressure, you can still force in air, but when it comes about to recoil of the chest and there is some kind of resistance, that is going to be very prominent. So that's why when you see the curve, you can see a more prolonged or scooped out pattern in the expiratory phase, and the peak expiratory flow rate is also reduced as compared to a normal one, which is this white line. Here the peak expiratory flow rate is reduced and scooped out pattern. On a flow time, this will show as a decreased peak expiratory flow rate and a prolonged expiratory time. Where is that thing gone? Right? Decreased peak expiratory flow rate and a prolonged expiratory time. On a pressure time, it showed as a very high difference between the peak and the plateau. So same thing can be seen in different parts, then you can understand the same. Now pressure volume loop, here the volume comes onto the y-axis. In a flow volume, the volume was on the x-axis, here the volume is on the y-axis, and the pressure is on the x-axis. Here the inspiratory part, from here the pressure rises to the maximum and then comes back to the baseline. Based on that curve, you can see whether it's spontaneous breath or an assisted breath or a controlled breath. A controlled breath will start from 0. An assisted breath will have some movement towards the opposite side. Why? Because some amount of effort the patient himself has made. This is called the trigger work of breathing. And this small triangle should be as small as possible, or rather not visible at all, even in an assist control. If it is large and visible, your trigger work of breathing is too high, and you have to reduce the trigger or adjust the trigger so that the work of breathing to trigger the breath is reduced. Especially so in COPDs, where you are trying to wean, where they already have a lot of autopsy, so you have to set a trigger accordingly so that it does not cause more of a discomfort to breathe. On a spontaneous, it has both a positive aspect and a negative aspect, because here the pressures will go on both ways. PEEP, if volume is here, pressure is here, so PEEP means some positive pressure, so it starts from here. PEEP on this pressure time was shown as a rise from the baseline. Inadequate flow. On a pressure time curve, how was the inadequate flow? A scalloping of the ramp, which was from the initial part to the peak inspiratory flow. There was a scalloping out or a scooping out. Here again, during the inspiratory time, there is a scooping out. Air leak. Air leak is a volume phenomenon, not a flow phenomenon. So the volume is not going to reach the baseline. So air leak in all four aspects. Volume not reaching the baseline, volume not reaching the baseline. Here again, volume is not there, and here again, volume is not reaching the baseline. So when you talk about work of breathing, this is the resistive work, this is the elastic work. Increased resistance means, first of all, higher pressures and more of resistive work as compared to elastic work. So more amount of resistive work. Decrease compliance. Compliance is change in volume per unit change in pressure. Decrease in compliance means for higher pressure, lesser volume. That's what it means. So if you have volume on the y-axis and pressure on the x-axis, if this is your normal pressure limit for which this much volume was being generated, if the compliance falls, obviously more pressure is going to be required to try to achieve that volume. So this entire curve is going to fall towards the right. So on a pressure volume loop, if the compliance is persistently, suppose this is normal compliance, the middle one is normal compliance. If the compliance is improved, then more volume for some pressure, so that means the curve will move towards this side. This will be better compliance, and if it is decreased, it will be more towards the right, lesser compliance. Which kind of is it a volume control or a pressure control? Because all of them are ending at a specific volume, so it is a volume targeted mode. Had this been a pressure targeted mode, then how will the same graphs be? So it will be different volumes for the same pressure, and that's exactly what it is, different volumes for the same pressure. Right? As the compliance reduces, the volume keeps coming down. This is worst compliance, normal compliance, better compliance. So each mode has specific nomenclatures. A volume targeted mode is basically time trigger. The trigger is time. What else? What are the other type of triggers that you know of? Grossly, patient, and time trigger. Okay. So patient trigger can be flow trigger, pressure trigger, and a neural trigger, as in now. So these are the type of triggers which you have. If it's time trigger, it's a totally controlled mode. If it's patient trigger, it could be all of them: flow, or pressure, or neural, whatever be the kind of ventilator you set. So it is considered to be time trigger. Flow limited. So flow is a fixed variable, pressure is the independent variable, and volume cycle. So once the volume is achieved, it will cycle on to exhalation. A pressure targeted ventilation, like pressure controlled ventilation, is again time triggered, pressure limited, and time cycled. After specific inspiratory time is over, it will cycle on to exhalation. If it was volume assist control, then it will be patient trigger, yes, flow cycle, flow cycle, flow limited, flow cycling नहीं हो रहा है, flow cycling सिर्फ आपकी pressure support में होता है, बाकी किसी में नहीं होता. ठीक है. फ्लो लिमिटेड, फ्लो इज अ फिक्स्ड वेरिएबल. मैंने सिर्फ वॉल्यूम असिस्ट कंट्रोल की बात करी है आपसे. असिस्ट कंट्रोल का मतलब है बस ट्रिगर पे इफेक्ट हो गया, बाकी सब चीजें सेम है. सो द ट्रिगर इज अफेक्टेड हियर. द ट्रिगर इज प्रेशर ट्रिगर. What that may be, whatever you have said, whether flow or pressure or whatever you have said. So totally pressure trigger. Baki everything else remains the same. So volume assist control is patient triggered, flow limited, volume cycled. There's two aspects. The cycling and the limits were the same. SIMV, how will you describe it? Yes. So here there is a triggering by the patient. Yes or no? There's a negative part. So it's patient trigger. Okay. Then this is volume targeted SIMV, not pressure targeted SIMV. So rest of the factors remain same as volume target ventilation. Pressure support ventilation. This is the only one which is flow cycled. Right? It is patient triggered. Obviously it's a spontaneous mode, so it has to be patient triggered. Cycling here is flow, not time. Cycling here is flow. What does it mean by flow cycling? Meaning that once the flow reaches a certain proportion of the maximum flow, the ventilator decides that here he has reached the end of his breath and now he has to move to exhalation. So when we breathe, initially we inspire very fast, and towards the end of a breath, as the pressure within the chest is building up, your flow becomes lesser and lesser and lesser. That's what you do in your normal breath. That's what the ventilator also senses. And it thinks that now the flow has fallen to 25% of this peak flow. There I should cycle on to exhalation. This 25% is the default. It can be changed in ventilators, in certain ventilators, to 35, 45, whatever you wish to do. So flow cycling, the flow will not reach the baseline. It will cycle as soon as it reaches some proportion of the peak inspiratory flow. There it is going to come. So that's what will show you whether it is flow cycling or time cycling. Had it been time cycling, this flow would have reached the baseline and then started from the baseline. So that is time cycling. If it is flow cycling, it will stop before above the baseline at a certain proportion of this and then cycle from there. That's how you differentiate between a pressure support and a pressure control, because rest of the parameters are the same. Assist pressure control and a pressure support will look very similar, right? They are both pressure modes. So both can be pressure triggered, because assist pressure control and pressure support are both. The only difference is cycling. That is time cycle, this is flow cycle. So pure SIMV will have some mandatory breaths and few spontaneous breaths. If it is SIMV with pressure support, then you will have a few flow cycle breaths in the middle. Pressure support versus CPAP. CPAP is a totally spontaneous breath. May have different volumes based upon how much ever the patient is willing to take. Asynchrony. Now this is something which I just want to touch upon because not too much in it. It's a mismatch between inspiratory efforts and the ventilator support delivered by the ventilation. So the ventilation is based on presumptions that this much should be the inspiratory time, this is the time when the patient should exhale, this is the amount of pressure the patient requires, this is the amount of flow the patient requires. It's based on your clinical judgment of the patient. That's how you select the modes. But it's not always the patient requires all those things, so they can be asynchronic. It can be subtle to overt fighting the ventilator. So types of asynchrony. First of all, the first phase was trigger. So first trigger asynchrony. So there can be different type of trigger asynchrony. Trigger delay, double triggering, miss triggering, auto triggering. Second is flow. Flow related asynchrony. Flow is not enough to meet the patient's demand. Third, cycling asynchrony, where there is poor coordination between the patient's desire to exhale and the ventilator's opening of exhalation valve. So these two are asynchronous. This is because of an inappropriately long inspiratory time or an inappropriately short inspiratory time. Both can lead to cycling problems. And finally, inappropriate mode. Altogether, your mode is something the patient requires something else and you are given a totally different mode. Wasted efforts or ineffective breathing. You can see here, every time the patient there is one trigger, one more trigger, one more trigger. This trigger is associated with the breath. There is one more trigger, no breath, one trigger, breath. So each time the patient is triggering, it's not accompanied by a flow and a breath. If you see that pattern, the patient is making ineffective efforts. So what do we do? What is the solution? So yeah, so this is how it is. So what do we do? What do we do? Trigger sensitive PVA set. In case it is still not working, then set it. Ultimately, everything comes down to set it. Okay, double triggering. Now you see, one breath, two breaths, suddenly two breaths together, and then one. So here, what's happening is that two breaths are being triggered in one single cycle. So if we have an expiratory flow trigger, sometimes, as I said, 25% is the baseline, but we can always set this baseline different. If we make the baseline say 35-45%, or if we make the baseline even lower, what is the meaning of both? If we set the expiratory trigger as 15%, so we have given more time for inhalation, right? Double triggering occurs when the patient's efforts, the flow is not enough to meet the patient's efforts. Patient requires much more, and he requires a much more longer inspiratory time, but you are not providing that much inspiratory time. So one thing to do is, especially on a pressure support mode, is to reduce this trigger from 25% to say lesser. This is seen classically in patients of ARDS, especially when they are requiring a very high requirement and you are not providing the same requirement. The high requirement because of a high PCO2, the requirement is too high. So high respiratory drive, low tidal volume, and a short inspiratory time. These are the three things which leads to double triggering. Patient is trying to trigger more and more than what is actually being delivered. Solution is increase the inspiratory time. So you can opt for a decelerating mode. As I said, as compared to a fixed mode, a decelerating mode gives a longer inspiratory time, proportionately longer inspiratory time. So instead of shifting from a volume control, you can shift to a pressure targeted mode. Increase the tidal volume, but this is not a thing which you do in ARDS, so that is a possibility, but we should not really follow that. From a volume, you can go on to a pressure mode, and even on a pressure mode, if it's not working, you can always increase the inspiratory time by increasing the inspiratory phase by reducing the cycling time. Instead of 25%, you reduce the cycling to 15%. So till the time the flow falls to 15%, it will not cycle on to exhalation. The inspiration period will be prolonged. So these are the ways you can combat double triggering. And finally, sedation paralysis. Auto trigger is too sensitive. Any kind of movement is triggering. There are lots of causes. Very poorly set trigger, very low. Cardiac oscillations, leak from a bronchopleural fistula, water condensation, large amount of secretions, peristalsis in a hiatus hernia, muscle contraction because of pacing, or transmitted patient pulsation because of patient movement. You just press on the patient's abdomen, and the machine senses that this is a negative inspiratory effort and gives a breath. So this is kind of thing. So obviously you have to adjust the trigger to a higher settings. Third, if flow rate is inadequate, we have seen this scooping out of the inspiratory waveform. We saw that. Solution: we increase the flow rate, but flow is fixed in volume control. You can't increase the flow rate, right? So flow is fixed. So you convert it to a pressure format where the flow is variable. One. Okay. Second, you can always increase the sharpness, the rise time. So you are providing a very fast flow to start with, right? So that flow hunger is not there. So you reduce the rise time. There's one button called rise time. You're wondering what's the rise time for, but this is exactly for that. You reduce the rise time so that the flow is reached faster. The rate of flow is reached. Now coming to cycling, premature cycling. What does it mean? The patient wants to inspire more, but the patient ventilator has decided no, exhalation has to start. So here you can see when you talk about the flow is coming down. Here still is trying to make some positive effort, trying to draw the air back into the patient. That's why there's an upward spike here. The air is trying to come back into the patient. So this is premature cycling. Very classically, just put this into your mind. This is how it looks like, premature cycling. So why is it premature cycling? Inadequate inspiratory time period set. You can always increase the inspiratory time in a pressure control waveform. In volume control, you can decrease the inspiratory flow or increase the tidal volume. These two things can also work in the same way. In pressure support, this is very common, especially in patients with ARDS. So if we have too high a cycling threshold, we decrease the cycling threshold. As I said, decrease it to 10% so that you have more time for inspiration. The idea is to increase the inspiratory time. Then only the cycling, premature cycling will be stopped. Delayed cycling, classically it looks like this, horn on your pressure curve. If you see this, you can understand that is delayed cycling. So basically the inspiratory time is too long or too short? Too long. So you have to reduce the inspiratory time here. So in pressure control, we will decrease the inspiratory time. In pressure support, it is too low a cycling threshold. So what you do, instead of 25%, you set it at 35% or 45%. This is very commonly seen in a very common scenario, non-invasive ventilation. Because of the leak, the cycling never occurs because it is never pressurized to that level. So that's the reason why instead of 25%, you set it at 35, 40, so that you can always cycle from inspiratory to expiratory. So delayed cycling is very common in non-invasive. Non-invasive have 100% asynchrony. It is taken 100% asynchrony. So you can do the best to try to make as much coordination between the patient and the ventilator as possible. And one of the most common kind of thing which you see in non-invasive is delayed cycling. So there you have to change the cycling threshold, right? So role of inspiratory leaks is there. Take home points. This is an integral component of managing a patient on mechanical ventilation. Always make it a habit. Always look at both the inspiratory and expiratory part of the flow waveform. Do not hesitate to change the scale or the speed to add to an interpretation. And at any stage wherever you're confused, you can always ask for help. So that is something which one should never be shy for. Thank you. Yes, somebody asked.